Well, good afternoon, everybody. I hope you can hear this. My name is Hugh Constant. I am a practice development manager here at the Social Care Institute for Excellence, and I am organising a series of learning and development sessions on behalf of the Better Care support team and the Better Care Fund. Among those are a series of 6 webinars, of which this is one, but do check out our website for dates of the others. But today's webinar is, as you can hopefully see, around the topic of personal health budgets, integrated personal commissioning, and the role they can play in the sort of Better Care Fund's aims of smooth transitions and preventing delayed transfers of care. I'm really pleased to welcome and have with us here Alison Austin, who's the Head of Personalised Care Policy for NHS England, and her colleague Stephen Pruner, who is the Senior Manager for Personal Health Budgets. You are also later on in this afternoon session going to hear from Rob Moriarty about his lived experience of having and using personal health budgets. Okay, so Alison, Stephen and Rob are going to talk to you. We'd like you to engage, that there will be some questions that Alison will put to you, but also at any point we'd be really keen to hear from you in the chat box, which hopefully you can see on your screen. So if you have any questions or comments about what Alison, Stephen and Rob are saying, put them in the chat box. I will busily be collating those, and we will have a slot at the end of the session to where I can put those questions to the presenters. So yeah, do engage as much as possible through the chat box. So yeah, sit back, enjoy, and I'm now going to hand you over to Alison. Okay.
Thank you, and thank you for giving me the opportunity to come and speak today. Oops, I had said that I knew how to work the slides, and I don't. Oh. There we are. Apologies for that. So what we want to do today is to have a bit of an introduction about IPC and personal health budgets, where we are in terms of policy, and then we're going to hear from Rob, and then hand over to Stephen to do a more practical, how do you make personal health budgets work on the ground, and then get into a bit of a discussion about the impacts of personal health budgets on DTOC, bit about what we know and what we've found out so far, but also an opportunity for you to discuss that. So first of all, it's worth saying that there's a lot of focus on personal health budgets. There's been a lot of media interest recently, but actually they're just part of a wider programme of work around personalised care. So how do we change relationships between individuals and the professionals that are there to support them, to empower them and enable them to develop the knowledge, skills and confidence to manage their health, their well-being and their life. So a lot of programmes around shared decision making, around choice of hospital, when people need to go get referred to hospital, but also things like horrible term patient activation. So it's a measure and a way of understanding how people's what their knowledge and skills and competence is around managing their health through care and support planning and social prescribing up to personal health budgets and integrated personal commissioning. So, sorry, I have got a frog in my throat. So the first question, just to get a feel for how much you know about the agenda, is whether you could indicate whether you are an IPC site or not, or whether you know there's an IPC site within your area. That's good. There's a good mix there of people who know about IPC and those that don't, which is good. So for those of you that are less familiar with IPC and personal health budgets, what they both are is they're about empowering people, enabling people to focus what works for them and what's important to them. Integrated personal commissioning is a system-wide approach to personalisation, to integration at the level of the individual, and personal health budgets are a tool to enable people to do things differently and to commission or have care and support that would not normally be traditionally commissioned by the NHS. Integrated personal commissioning, it's for people with very high or higher levels of need. The aim is to prevent the crises in their lives that would mean they end up in hospital or institutions. It's about improving quality of life and better integration and quality of care. They're aimed at those, as I said, with special educational needs and disabilities, people with multiple long-term conditions and frailty. So people who have more complex needs. At the moment, we're in a demonstrator phase. In last year, there were around 42 CCGs involved in the programme across different IPC sites. Okay, personal health budgets, just to, again, very quickly whiz through. They were piloted between 2009 and 2012, which showed that they're cost effective and they're a good way of shifting care away from urgent and emergency care and into pre-planned care and support. They reduce hospital admissions and some of that acute phase stuff. People have a right to have a personal health budget if they're in receipt of NHS continuing health care. There is at the moment a consultation out, live joint DH NHS England consultation out, exploring where else we might introduce rights to have personal health budgets. This consultation runs until the 8th of June, so if you're interested, you can find links from the .gov website or from the personal health budget website. One of the areas we are looking about is those individuals who receive individually commissioned packages of care. Should they have rights around personal health budget? Because we know at the moment they've got rights in social care around personal health budgets and then the right in continuing care. And there's this group in the middle that receive both, and shouldn't we be levelling the playing field? Just another very quick recap. Personal health budgets aren't about new money, it's about using money differently. It's about transparency and it's about changing the relationship between individuals. When we're not talking about new money, we've got to find money for continuing healthcare, things like Section 117. It's relatively easy because there's a lot of individual commissioning goes on anyway. But it becomes more difficult where you've got large contracts in place. And we're doing a lot of work within the IPC sites and our PH champions to really bottom out how you can do that at scale. So at the moment, we have a large number of personal health budgets. There's over 22,000 of them. 4,620 of those in the first 9 months of this year were for integrated packages or joint packages of care. So I'm just interested from your area, how many, whether you know, of course, you may not have the numbers to hand, but where you've got people who are eligible for joint packages of care, how many of those are personal budgets, integrated or joint personal budgets? Yeah, it's interesting. Of those people who've responded so far, it's all less than 25, and I think that's is is very reasonable, considering we're at a very early stage with integrated personal budgets. There are some areas, some CCGs that have got high numbers of personal budgets, particularly around learning disability and support for people in the transforming care cohort. Okay. So we've got set a national ambition was set out in the mandate for personal health budgets, which is between 50 and 100,000 personal health budgets by April 2021. We're on track for that. There are around just under 23,000 personal health budgets in the first 3 quarters of last year. We're just waiting for the end of year results, but it's going to be in over 26, 27,000. I think it's going to be in that sort of ballpark, but then I am an enthusiastic person. What that means is we are on target, not just to meet the lower band, but actually to meet the higher band of personal health budget numbers by 2021. CCGs have set their own trajectories and submitted those about how they're going to meet their share of the commitment, and we're monitoring that through the process. What is interesting to me anyway is the shift over the last 3 years around the numbers within individual CCGs. There were originally very, very few, there's only 1 or 2 CCGs that had more than 50 personal health budgets, and an awful lot who had less than 5 personal health budgets, and there's been a significant shift in that. The right to have a personal health budget has helped support that, but it's interesting to know that the numbers in integrated budgets, the numbers in other areas are relatively high as well, which I think is really useful from our perspective. The other thing I thought it would be worth talking about in terms of policy terms is, some of you may know this already, but on the 20th of March, Jeremy Hunt announced 3 new integration pilots. I hear those of you that have been around for a while, no, not more integration pilots, because we've been doing it since, I don't know, 2002 and 2003. And what's different about these? So the aim is for these 3 areas is to look at using the integrated personal commissioning model, so that idea about working through care and support planning, working through what's important to people and integrating across health and social care, to bring that further up. So we start doing some work around preventative health and social care assessments. So how can we bring knowledge and expertise about an individual's long-term condition, how well they manage it, what support they need to manage it, and can we do things to help them support their long-term conditions in an assessment approach, rather than are they eligible for statutory services, whether that be health or social care. Following that, and this is obviously integration at the level of the individual, rather than some of the integration programs which are focused on system level integration, which is also important. Following on from the assessment, these individuals, and it's everybody who is eligible or everybody who's been identified as may benefit from social care and likely to go in and have a social care assessment under the Care Act. It follows on from that those individuals will have an IPC approach to care and support planning. Some of them won't need integrated personal budgets or won't need a lot of support. Other ones may well be referred to things like social prescribing or the voluntary sector for help and support, or things like health coaching or self-management education to help people develop the skills and confidence to manage their care. Okay, that's the end of the policy point of view. I'm not sure whether Rob is on the line. Okay, so I'll pass over now to Rob Moriarty.
Hello, can you hear me? Hello?
We can hear you, Rob.
Sorry, Sorry, I'm having a few issues with my microphone there. Can you hear me now? Okay. Right. Okay. Can I just clarify first? Was it my personal health budget bit you wanted me to talk about, or delayed discharge?
Both.
Both. Oh, right. Okay. How long have we got?
You've got it, yeah.
In which case, I will try and be as brief as I can then, so as not to take up the whole afternoon. I suppose the initial caveat to this is I've had a spinal cord injury for now. It'll be 20 years this year. So a lot of my initial experience from being in hospital and then first coming home was around kind of 1998, 1999. And I know when I chatted with you about this, Alison, I did actually ask if anything had really changed in the last 20 years, and you kind of shook your head almost straight away, so it probably is still fairly applicable. I think one of the initial things that we found when I was first trying to come out of hospital, I was initially told that I would be in for anywhere up to 2 years going through rehab at the National Spinal Injuries Unit. And broadly speaking, I was ready to actually come out after about 9 months. The first major sticking point that we actually had for getting me out of hospital was that there was no way of being able to shower me at home. My parents actually had to move from our house that we'd been in for about the previous 6 years into a bungalow that was far more accessible for me. But there was no wet floor shower or anything in there. The only option at the time that we were really given was going to a local community centre where I could have a delightful shower probably about twice a week or something like that. My mum flat out refused to let me have that. So the only option that she could really come up with at the time was using a paddling pool. And we had that in a bathroom. She got a shower head extender, and we would shower me over that for the best part of about 6 months whilst the disabled facilities grant was being put through. And that took probably the best part of about a standard 6 months, as it usually does. And we did that. Now, you can probably imagine getting a shower chair into a paddling pool is not too bad. Being showered by it wasn't too bad either, even though I often ended up being the driest person in the paddling pool. But then actually trying to get the shower chair out of the paddling pool when it's full of water basically just makes an absolute mess everywhere. What we could never understand at the time was why that application process could only start the day after I came home from hospital. That property was never mine. My name was never on it at all. It was the only place I was ever going to go back to. And the fact that they actually moved into it 5 months before I eventually came home, I can't understand the reasons why. I mean, obviously there were reasons in terms of policy and stuff, why the application process couldn't have been started way back then, and I may have been only waiting a matter of weeks before, having that wet floor shower in place, rather than the months that it ended up being. So certainly that's been my initial experience of that kind of transition between the hospital environment and the home environment, where it just seems that everything starts the day after you come home. To my mind, the better way around that should actually be the first day that you go into hospital. Everything should be geared around, okay, how are you going to get you back into the community? And if there's any bits of policy, which I have no idea what they are, that basically says you have to be living in the community or you are deemed to be a permanent resident whilst you are in hospital, get rid of those lines. And it would make that kind of integration between the hospital environment and the home environment far better. Even if I'd have been in hospital for up to, the best part of 2 years and that wet floor shower was in place before I came home, I could have actually gone home more often and been less of a burden on the system that way, to my mind. But kind of more broadly speaking on personal health budgets, they really have been a bit of a not necessarily a lifesaver for me, but they have given me far more flexibility than the health and social care system ever really did in the previous kind of 17, 18 years. I've had just about every aspect of the care system thrown at me. I've had agency care, I've had the parents looking after me, I've had a small team of PAs that looked after me at university, and since 2005 onwards, I've been on either direct payments, personal budgets, personal health budgets, you name it, continuing healthcare as well. When I was on direct payments, I found that it worked for me pretty well, but from about 2010 onwards, it was getting increasingly restrictive, not only because my PAs were on the same fixed hourly rate for the best part of about 4 years. I was asking them to do more stuff, and to be perfectly honest, it was the kind of stuff that I needed them to do that is not a minimum wage job, particularly around some of the kind of, the healthcare tasks that I needed doing, which were being missed by the district nursing service, who were having to come into me every other evening. And if you just work out the basic maths of that, that's 180 odd times a year, where every other evening I had to be at home. They would be coming anywhere between about 6 and 10 in the evening. We usually got to the point where if I wasn't the first to be seen, I would be the last. But you could guarantee that one moment where you're about to put either food into the oven or that first mouthful of food into your mouth, that would be the moment where the nurses would ring and say, "Can you get on your bed, please?" So more often than not, I actually got used to eating things like frozen meals or eating late on in the day, which I could just about make work. But for things like going on holiday, or even just being able to go away and do kind of holidays or kind of work away from home, I just found that was being too restrictive. So for me, personal health budgets were a bit of a liberator, because my existing team were actually trained up on doing all of my healthcare tasks so that I could do them in-house. And they've all done that now, and dropping from whatever 185 visits that I used to have on a yearly basis. In the last year, I had 6 visits from the district nurses. This year so far, I've had one planned one at the beginning of January, and there's going to be another one this weekend. And both of those weren't actually for me. They were for my PAs to be observed on some of the tasks that they have to do. So the number of visits that I've had and my contact points with the system as a whole have absolutely plummeted. That is not only giving me more flexibility to kind of live my life and actually do more work. In fact, I've actually managed to treble the amount of work that I can do in the last year, and going all over the country. And in fact, just this last week, I was over in Copenhagen delivering a presentation on exactly this sort of stuff. But it's also saving the system money at the same time. I did do a bit of digging around the bowels of the NHS archives, and I found that a 20-minute district nurse visit back in about 2010 was costing about £50 to the system. If you include the fact that they had to have a second person with them, if you say that's about 90 odd pounds per visit, over the course of a year, you're looking at the best part of about 16,500. If I'm saving that amount of money and also paying more tax on behalf of my PAs within the increased hourly wage, that's starting to save the system some significant chunks of money, and reducing my need for any kind of contact points with the system, and means that the nurses can actually go and spend that time with other people who are more in need of that kind of day-to-day contact from the nurses. So for all of those reasons, personal health budgets for me really have been a massive liberator, and probably given me more flexibility than I've had in the last 20 years with a spinal cord injury. And so that's probably been, broadly speaking, my experience, and about as short as I can make it without going on for about 2 hours.
Great. Thank you very much, Rob, for your time and your honesty. And thank you for saying nice things about personal health budgets.
Quite all right. Is my check in the post?
Thank you. I'm now going to hand over to Stephen to do a bit of discussion around making personal health budgets work on the ground.
Thanks, Alison. Good afternoon, everyone. I'm Stephen Pruner, and I lead on PHB delivery support to CCGs in the London region. And in this part of the webinar, I will show you the steps required in a PHB process. There are 6 steps in any PHB process that's in place locally, and each of these steps are essential and cannot be left out because each serves a particular purpose. The 6-step process underpins all PHBs, regardless of the cohort or service. It doesn't matter if the PHB is intended for someone with dementia, a wheelchair user, or a child with complex needs. The steps are all the same. From the diagram, it appears that the process is quite straightforward. That's a smooth process, but it may not be, because there may be issues locally where each element or step hasn't been refined enough. So, for example, the time it takes to set up a PHB, going through each of those 6 steps, can vary. And they could vary depending on the complexity of the care needs which need to be supported, or the time it takes to recruit and employ PAs. There may be pre-existing care and support arrangements that you need to transition to something that the NHS can support. That might be private arrangements which need to transition to meet various regulations and legislation, such as non-CQC registered PA partnerships or cash-in-hand arrangements, self-employed PAs. There may also be a level of risk that needs to be managed. That might be around financial and clinical risks. There may also be issues with the speed with which decisions can be made to agree an indicative budget and flexible budget spend, and perhaps signing off the personalised care and support plan. And of course, the skills and the confidence of the staff involved in supporting the process may also add extra time to this process. And how robust your underlying processes are. You've got to have clear roles and responsibilities for everyone. And you've got to have clear information for individuals and the families, good budget setting, and even a personalised care and support plan template. The last slide in my section of this webinar will cover governance arrangements. Over the coming slides, I'm going to take you through each of the 6 steps. But first, I want to talk about this slide, which is about implementing and setting up a PHB process. To ensure you have a PHB process that is straightforward and as smooth as possible, creating a positive experience, because this is what we want. We want to create a positive experience for the individual and their family or carers. You will want to tailor the PHB process specifically for DTOC. The 6 steps themselves won't change. You need to have all 6 steps in place. However, the process will need to fit around and work with your DTOC arrangements. If not, it may create a negative experience for the individual going through a discharge process. So before setting up and implementing the 6 steps, ask yourself, in the cohort you're looking at, who would benefit the most? Start with this group and take them through the 6 steps at a pace and in a way that makes sense for them as you refine your end-to-end process. It would be better to start with 1 or 2 individuals going through a DTOC process and taking them through your 6 steps. You would be in effect testing out how well your processes are working. Find a lead clinician in your DTOC pathway who can take on the role of a PHB champion, so the process is clinically led with an emphasis on the individual, the patient if you like, going through the process. This champion will help you deliver a smooth PHB process, ensuring feedback to you with what's working and not working so the process can be refined. Together, you can work out and understand the core elements that everyone needs to know and what needs to be in place, and even what training staff will need. And if PHBs are already being delivered in your area, and they should be because of right to have under continuing health care, I don't think there's a single CCG in the country now that's not delivering PHBs. So look at the processes that are in place. What can you use from existing PHB delivery processes and infrastructure already in place to help you deliver PHBs in DTOC? Do not reinvent the wheel. And look at who you need to be involved to help you set up and implement PHBs in the DTOC pathway. So I'm going to go through the 6 steps now. Step 1, The regulations on direct payments in the NHS make it quite clear that the CCG has a duty to provide information about PHPs. By having the right information available about PHPs and your process, this will help people understand PHPs and it will support better decision making. No one's forced to have a PHP. But to make a decision about having a PHP, the individual needs to be fully informed. And the information should be in a variety of formats. It needs to cover what is a PHP, how they can be used, and the steps to getting one. And the information also has to include relevant contact information. Some people will require support to make a decision or to go through those steps. And your information should include support around that, around the decision making and about accessing the information. Now, it's likely your CCG or your continuing healthcare team already have this information, already have leaflets and in various formats available because they're already offering PHPs. So find out what already exists and see if you can use that. Use that as a starting point to develop appropriate information for a DTOC pathway. And regardless of who delivers the information and how it's provided, it will need to cover the process itself and how the process starts, sort of the initiation of a PHP process. So the staff working in a DTOC pathway or the staff working with the individual, that may very well be nurses or other clinicians, they may need to have training on how to have that initial conversation about the options and about how a PHP might work for the individual. And it's also very important that the information is transparent from the beginning so you can manage expectations, especially around the amount of resource available and how flexible the use of the budget will be. PHPs are not new money. There is no more money in the system. It is about the same resource the NHS would have provided in a more traditional way, but now it's through a PHP, so the individual, as Alison said earlier, to exercise more choice and control over that resource and how it's used. Step 2 is really about the assessment and an understanding of the care needs of the individual. You need to have a really clear picture of what the care needs will be or are on discharge. In a way, it's almost the 5 W's. I mean, not quite, but the who, what, when, where, and why, in a way. You need to know who will be involved in the assessment, what their role is, who's leading on the gathering and the collation of the information, when that will happen, and is it proportional and person-centered. When you're setting up your PHP processes, you need to be clear about the current systems you have in place for doing assessments, and is that working well? Does that need to change? And how will that fit with a PHP process, particularly within a DTOC pathway where there's very often a lot of pressure to discharge people as quickly as possible? So you need to ask yourself, do you need to review your current assessment process and procedures to ensure that you are gathering the right information, you're involving the individual themselves and their family or informal carers, and that it's very much outcome focused. Step 3 is a very big part of the 6-step process, and I will spend a couple of minutes on it. Step 3 will require a lot of work before you can fully implement your PHP process. Before an individual can even begin to work out the care and support that they need, a bit like going shopping, they have to know how much resource is available to them, and this is what we call the indicative budget. It's indicative because once the personalised care and support plan is completed, signed off, agreed, and the budget to allow the individual to implement it, that budget may need to be adjusted. So working out the indicative budget does require some underpinning information. So you need to know the cost of services. You might use a tariff as a reference point. You might use reference costs from the local community for services. You might want to check with your local authority about the costs of various services in the area, but you'll need to know the cost of services. You'll need to know perhaps the cost of a typical care package, a theoretical care plan, for example, of what is traditionally being spent, to give you some idea of what an indicative budget might be. You may need to know the costs of new or potential services that people might use out in the marketplace, from either existing providers or new providers who might be entering the care and support market. You'll also need to understand the organizational risk if you don't know the cost of a traditional offer. So you'll need to do some work working out the unit costs and the costs of providing care and support in the community in the traditional way. This is a lot of work that needs to be done either by the commissioner or a project manager working in the CCG to truly understand the cost of services. The big question is, how do you release money from block contracts to generate a budget? Because the money has to come from somewhere. You also have to work out how you're going to set your budgets. You may use a RAS system, a resource allocation system. You may pull money out of contracts. You may not just be able to pull money out of a block contract. You will need to have very good relationships with your providers if you're going to start varying your block contracts, because you want to make sure your block contracts remain stable and sustainable. It might mean a little bit of double funding in the short term, if that's the way that's going to help you move forward. If it's a way of making sure that services can be provided at the same time as providing funding for PHBs. So I'll just give you a brief summary of some ideas of how you might be able to fund PHBs. Just a quick summary, which is you might double fund for a very short period of time. You might use a local sequin to set the rates. You might, to help set rates and acquire funding. You might set up a gain and risk sharing agreement with your provider. You might try to reduce growth in provider funding. That will help release a bit of money. You might set up a specific spot purchasing budget and fund that. You could identify where there's issues in services and work to change those services, and at the same time, in looking at those services and changing them, release money that way. You could look at top slicing. You could take a service-by-service approach. You could look at capitated budgets. So there's a number of ways that you can pursue to help release money to fund PHBs. And none of these are mutually exclusive. We have sites that are trying more than one approach to ensure that funding is in place for PHBs. But once you've got your budget setting model in place, the key thing is it has to be consistently applied, and you should be able to scale it up. And of course, you need to be clear with the individual about how much resource is available and which elements can be given as a notional budget or as a direct payment or would be managed by a third party. The individual should always be given the choice about how they wish to manage the money. I've mentioned the 3 ways it could be managed, and you need to be clear to them about what elements could be given as a direct payment. That might be the whole budget, it might only be part of the budget. Whether they want to have a notional budget where the money stays with the CCG and spends it on their behalf under the direction of the individual, or it could be managed by a third party. But in all cases, the budget has to be clear, it has to be upfront, transparent, and there has to be enough money in the budget. The individual should know how the budget was set. And the funding, of course, needs to be available up front, because NHS Care and Support is always free at point of use, so the money has to be there up front. The whole process has to be transparent, including the rules, so expectations are managed. And of course, as I've already said, the budget has to contain enough money to allow the individual to implement the agreed care and support plan to meet the agreed outcomes. And you need to be clear about a dispute mechanism and how issues will be resolved. So some top tips, if I could give you some top tips. Understand where the budget will come from, how you will fund it. I've given you already lots of information on that. And I think you will need to engage with your finance people as early as possible to begin those discussions, particularly with finance and your provider. Study the current use of services and speak to clinicians about what is working and not working. Be clear on the health needs that will be supported. Don't overcomplicate your budget setting process. And if you're using a RAS system, resource allocation system, again, don't overcomplicate it. And ensure there's enough money in the person's indicative budget to meet their assessed needs. Learn from local existing budget setting models. Look at what you're doing in continuing healthcare. Look at your joint funded arrangements with your local authority. What is your local authority doing? How are they managing and understand the market rates for PAs and agency costs and so on? Step 4 is about the care and support plan. And this is the area where the individual can really begin to express how they want to manage their care and support needs. This provides the opportunity to describe the outcomes they wish to achieve. And they should be invited to be involved in the writing of the care plan. And they should be given the support they need to be involved and even lead on the development of that care and support plan. Of course, they've got to know what the indicative budget is. So before anyone begins planning anything, you need to know what resource you have available to you so that you can write a care and support plan that makes sense to you. Of course, that care and support plan needs to be signed off. So once it's written down, the outcomes are clear, how those outcomes will be met, that will need to be signed off by a clinician and or whoever it's been set up as the person to sign off the care and support plan. And of course, I'll go back to this at my last slide when I talk about governance arrangements. The care and support plan also needs to cover risk. It needs to cover contingency planning. And the final bit is finalizing the budget once you've got that signed off care and support plan. So the top tips I would give to you is ensure that the person's at the center of the care and support planning process, this step 4, that the health outcomes are agreed between the individual and the health professional, that everyone understands the flexibility around how the PHP can be used, and ensure the individual can access support services that best suit them. It's got to be realistic. And ensure that you're clear about the services that people can access, and that it's only one part of a wider element of support that might be available in the community, such as support from VCSEs and your wider universal offer. And remember, the aim of personalised care and support and PHPs generally, it's to give people more choice and control. Once the care and support plan is agreed, we're on to step 5, and the care and support plan has been signed off and you've got a budget that's been finalised and the individual is now ready to implement the care and support plan. The CCG, or whoever's doing this process on behalf of the CCG, will need to ensure that there is support available to help the individual. The individual has to have the right information in order to implement the care and support plan. They might require information about how to be an employer, how to recruit personal assistants. They might require brokerage support to help navigate the marketplace, to source a care package. PAs might need training to be able to carry out certain healthcare tasks. The individual with the PHP cannot be left to their own devices. They're going to need support to help them manage the PHP. Of course, all the paperwork needs to be in place. That might be the PHP agreement. That PHP agreement is going to spell out the obligations and the rules around having a PHP. And we promote strongly involving VCSEs in helping to deliver a PHP process. There will be a role for VCSEs in terms of supporting individuals to connect with services, to connect with peers who already have PHPs, and to support them to better manage a PHP. And finally, we're on to the VCSEs, for those who are not sure, is voluntary and community sector and social enterprises. Even I'm struggling with VCSEs. So voluntary and community social enterprises. We got there in the end. Step 6 is really quite important, because all care packages, whether or not they're being delivered under a PHB or not, all need to be reviewed from time to time, particularly when there's a change in care and support needs. So to enable this to happen, it needs to be clear who will undertake the monitoring of the care package and the review of the care package and the PHB. These roles and responsibilities need to be set out in advance, and where possible, align them with other reviews that may be required to avoid duplication. Because the last thing you want is the individual with the PHB being visited by a series of people coming along month after month or even week after week doing a review on some element. Try to coordinate it. It avoids duplication, and it gives some sense of proportionality to the entire process. Not only should the care and support plan be reviewed to check that the outcomes are being achieved, the budget has to be reviewed as well, and to ensure that there is sufficient resource to allow the care plan to be implemented. Remember, it has to be, NHS care is free at point of use. So you want to be sure there's enough resource so the individual is able to implement those agreed outcomes, to achieve those agreed outcomes. You may have to address issues such as an underspend in the budget. It's quite possible that the PHB holder has been quite rational in the way they're using the resource made available to them, and so they're accumulating an underspend. So you'll have to have a view on how much underspend they're allowed to carry, and how you might deal with a request from the PHB holder to use that underspend in a different way. Because remember, PHBs, after all, are public money. You'll also want to monitor PHBs to ensure they're sustainable in the long term. There couldn't be anything worse than offering PHBs to an individual, whether it's in the DTOC pathway, to help meet their care and support needs on discharge, and then 6 months, a year down the road, it turns out you run out of money because they're not sustainable. So whatever cohort you're looking at, wherever you set up a PHB process, it's got to be financially sustainable. So here's some top tips to help you with step 6, is the individual has to have a named point of contact. So they know who to contact if there are particular issues they need to address. There has to be regular reviews that are proportionate. And so, for example, in continuing healthcare, it's required, the guidance is quite clear, you are required to have a review at 3 months and at least annually. You should be monitoring personal health budgets in the general sense for their impact on the wider system. That means the use of primary and secondary care services, perhaps keeping an eye on crisis episodes pre and post PHB, so you get a sense of whether the PHB is helping the individual to use less primary and secondary care services. That would be good evidence for you to take to either, if you're a provider, to your commissioner or to your finance directors, to continue to make the case that personal health budgets are a good thing from a financial point of view. But we know it's a good thing from a clinical point of view. We've got plenty of evidence for that. And of course, as part of step 6, you will want to measure individuals' experience, the patient experience, and outcomes. And the CCGs can use POET. POET is widely available to CCGs. POET means Personal Outcomes Evaluation Tool. And that tool will enable you to find out people's experience of having a PHB and if it's meeting their agreed outcomes. This is my final slide. It's the one I keep referring to because this is really quite important. Because as I've said, you need to have a very clear governance framework or process. And you need to know who's doing what across a range of elements. Because as I've already said, this is public money. And so you need to have a good governance arrangement in process. I'm not sure how clear this chart is on your screen, but you can see that it covers decision-making across both clinical and financial elements of a PHB. And I would suggest in each of the boxes, or each of the areas under the headings, there should be a named individual. So it's quite clear who does the assessment, who does the review, who agrees the care and support plan, who reviews the budget, who agrees the flexible spend. it really needs to be mapped out clearly so everyone knows who's doing what in the system, who's making decisions, who's signing things off. Now, some decisions might require someone at a more senior level to make decisions. So again, that person should be named. So if you're making a complex decision on a very complex care package that involves a large amount of money, let's say a couple of £100,000, do you want the clinician on the ward and the detox process agreeing that? Or do you want a senior manager or a budget holder at a very senior level, maybe even the director of commissioning signing that off? That needs to be in your governance arrangements. This ensures that there's trust in the system, and also ensures that the exercise of choice and control is within the rules. And we think that a chart like this will help ensure you've got good governance arrangements in process. Well, that's the end of my section of the webinar. Thank you for getting through these slides with me. I hope that's been clear. And I'm going to hand back to my colleague, Alison. Thank you.
Thank you. Before we move on to thinking about the impact of PHBs and IPC on DTOC, I see there's a couple of questions in the chat room that it might be useful if we answer those. The first one of those is around CQC regulated services and whether an individual with a PHB has to use regulated services. And the answer is no, that they don't need to use CQC regulated services. And if they're employing their own personal assistants, those personal assistants do not need to be CQC registered. When Stephen was talking about sorting out CQC registration, that's around if they're going to a domiciliary care provider. The domiciliary care provider should be CQC registered. Most of them are, because they use a lot of social care and healthcare funding more widely, but a few may not be because they are for private individual self-funders. The next question is around, can you use a personal health budget to purchase short-term or long-term care in a residential care? Yes, you can. There's nothing to stop you in the regulations from doing that. In social care, they don't use direct payments from in care homes, and that there's not likely to be a change in the social care side of things, because what benefit does it have in long-term care in a care home? I could see when you're thinking about intermediate care or step-up, step-down care, where that might be a different issue that somebody might want to explore using a personal health budget for. The last question that I can see is whether you can use a personal health budget for mental health needs. The answer to that question is yes. That's one of the cohorts beyond continuing healthcare where people really benefit from the choice and control that the personal health budget meet. We know that a lot of things that improve mental health are not traditional services, and indeed some of the services that we do offer and treatments we offer for mental health are not as effective as some other things. So it's an area where we are expanding, where we've got demonstrator and we've got champion personal health budgets. Does an individual have to have a CHC assessment in order to access PHBs? Definitely not. So individuals who go through the process and are eligible for continuing healthcare get the right to a personal health budget, and indeed those living in their own home, it should become the default. It should become the way of providing continued healthcare funded domiciliary care. But other groups, so people with integrated budgets who haven't gone through or have gone through CHC but aren't deemed eligible, can have personal health budgets. Each local CCG is supposed to have their own their local offer around a personal health budget, so explaining to their population who can have a personal health budget and for what services. Is it worth asking if there are any other questions or points of clarity at this point? Yeah, we can pick any up later on. Okay, so we got interested in delayed transfer of care last summer, and people have been asking about it for some time, about how can you use personalisation and personal budgets to solve some of the issues around discharge. People who are medically fit to get home, but can't do so for a number of different regions. We held a workshop which included 25 different organisations, a range of different organisations, from trusts, from health and social care commissioners, voluntary sector, and of course people with lived experience. There's none of our policy is developed without people like Rob in the Strategic Co-Production Group, who can really inform what we do and make sure that we get it right. What we did during this workshop was to first of all explore what's the problem. So what are the reasons that DTOC is an issue, and then going on to think through what's been tried before and what works, and then do some blue sky thinking about PHBs. This slide is going to be not a surprise to any of you who work in this area. A lot of things that came up with are that the discharge pathway is very complex. It starts very late in the day, so no advanced planning. Problems in some areas about local intermediate services, being able to get packages of care in place can be very complex. Lack of communication, lack of local knowledge about what's out there, and that people tend to focus on statutory rather than third sector organisations. Sorry, I should have said at the beginning, I have got a cold. So I'm a bit croaky, but at least you're not going to catch it because we're not in the same room. So some of the ideas that came out from this workshop about where personal health budgets and personalisation more generally could help were very clear. The idea that we need to start discharge planning a lot further up, and that planning needs to consider not just medical needs around discharge, but a holistic approach around the individual's whole life and what they will need to do, and thinking about what local resources are available within communities, and taking an asset-based approach, which is really good. As part of the Integrated Personal Commissioning Programme, one of the things that the demonstrator sites had to do very early on was have a very clear map about what is available in the local area in terms of voluntary sector organisations and different parts of the statutory system, to bring it all together so that there's a lot more clarity about that. Some of the things that people thought PHBs might help is if you needed intermediate care. So in Step Up, Step Down, that's funded through Better Care through social care, personal budgets were excluded from that process because it was a short period of time. But actually we think that it's worth exploring the use of personal health budgets or integrated personal budgets in that period to give somebody some extra support early on to enable them to get home, sometimes prior to formal assessments from CHC or otherwise. Another interesting idea was there are people in local communities, it may be somebody's neighbour, a close friend, even a relative, who may well be willing to do some, to act as a carer or a personal assistant for a short period of time, but they would never have thought of joining an agency and becoming a care provider in that way. So could we develop small hubs of people who were willing to help and use personal health budgets to fund those? The other one that's very interesting to me and links in to Rob's story is around PHBs for equipment, and how do we build together in the Disabilities Facility Grant and integrated personal commissioning and personal health budgets. How do we get that aligned up? There may be small pieces of equipment that may be stopping somebody from going home, but the application process for the facilities grant is going to take too long. And is there an argument for a trust to be able to then say, actually, it's more cost effective for us to do whatever small adaptation is? So that's the outcome of the workshop. We've gathered a lot of information. We got some stories from some areas about what they were doing and what they were trying to do. And there was a general feeling in that workshop that this was an area that we needed to explore more, and maybe think about developing some best practice or developing the thinking and ideas on that. And so that's something that we're thinking about as part of this current financial year. The last section is just to get a bit of your view and what's happening in your areas locally, or what you think, where you think the Better Care Fund might be able to help with some of these issues. We know that some areas are using the Better Care Fund for personal health budgets for specific cohorts to do some specific things, and obviously we would like that to continue. Example up there is around Luton and giving money to support people with dementia to be used on a variety of things. So people go into crisis, or as they're getting discharged from hospital, having a personal budget to enable them to get some extra home care for a short period of time is shown to be really beneficial. And Luton is one of our IPC sites. Second example was in Wiltshire, where they're using personal health budgets funded by Better Care Fund for informal carers breaks, so leading into and building into the carers strategy, which has been very successful. And there are other CCGs that are other areas that are interested in looking at personal health budgets to enable carers to continue to care for longer. And the final mention is of Birmingham, where they're using personal health budgets at the end of life and enabling people to get home from hospital and to stay and have the end of life experience that they want. We are doing a wider piece of work around personal health budgets in the end of life, and there's information about that on our learning network. So the last slide is really one to for you. What are your views on DTOC? Is there anything you're doing locally around Better Care Fund, personal health budgets, whether that's to do with DTOC or not, or whether you're interested in working with us to explore PHBs and IPC in DTOC or not? Got a question from Anne there. Rob mentioned one challenge was accessing the disability grant. How can IPC assist in this process? Likewise, if there's a housing issue. But this is where my utopia takes in, because I'm a policy wonk, which means I live in a world of perfection. What I would like to see is for the disability facility grant to actually come into the IPC process. It's already happening in a few places. We've got examples where the grant has been used to co-fund a wheelchair, so that people doesn't need a large kitchen adaptation. They've got one of those wheelchairs that raises and lowers. So I think there could be. I would like to see the disability facility grant. If somebody's got very complex needs, the sort of level of needs and support that Rob had, what we ideally should be thinking about doing, and we're doing some work with thinking with Sheffield and Manchester on that list at the moment, is how do we start doing discharge planning, maybe even if 6 months, a year prior to discharge, and start getting all of these things in place. enabling people to choose their own personal assistants and have them trained up when they're in hospital to kind of help increase detox, but also increase the likelihood that the care and support will actually work for the individual. So yeah, sorry, the disability facility grant is on our list of things to look at, and they're interested at working with us on that. Can people access private hospitals and therapies services with a PHB? Yes, indeed. I mean, there are some NHS funded services that are carried out within private hospitals now, so the personal health budgets aren't new in that regard. And yes, they enable people to agree to use therapies that aren't normally not normally commissioned by the NHS. The care plan is really, really important, as Stephen was talking about, that everything you've got to sign off, it's got to be signed off in your care plan as being something that's beneficial. What's fully funded CHC, what's the time scale for setting up a PHB? Stephen, have you any? My gut feeling is it's a piece of string because it may depend on the condition and what services are locally and what people want to do. But do you want to?
Yes, that's why I started off at the beginning of my presentation talking about time frame for the 6-step process, because the regulations don't lay out a time frame, and Alison is right. How long is a piece of string? I've done surveys when I've spoken to groups delivering presentations on PHBs, and I've asked people in the room what would they expect, and most people tell me they would expect a PHB to be in place within 2 or 3 weeks, that they felt that was a timely fashion to offer a PHB. But we know it can take, in some areas, 4, 5, 6, 7 weeks, because it will depend on the complexity of the case, the issues that are involved, if you're transitioning a care from private arrangements to NHS arrangements, and there's a lot of things to work out. But what I'd say is there would have to be good reasons to have a long period of time to provide a PHB. I would have thought if you've got mechanisms in place to issue the money, the payment mechanisms, whether it's on a prepaid card or transfer from the CCG systems to someone's bank account, that should be straightforward. And you've got your processes in place where you know who's doing the assessment, who's doing the care and support plan, who's signing things off, that you should be able to, I would have thought, within 2 to 3 weeks, you should have a PHB at least set up, ready to make the payment, because the money has to be paid up front, because NHS care is free at point of use. The individual can't spend a penny of their own money whilst waiting for the CCG to fund them. So the PHB has to be funded up front. And I would have thought if there's going to be a significant delay, that needs to be explained to the individual. Why it's going to take 2 months or 3 months to set up a PHB. And in the meantime, whilst the PHB is setting up, the CCG will, for example, if it's continuing healthcare, the CCG will have to fund a traditional package or a traditional arrangement in place. We have circumstances where a package might be transitioning from the local authority, and the local authority would continue to fund the care package and then recharge the CCG. This would ensure there's no disruption in the care, and the care arrangements that already exist would be able to continue. There would be people who already have direct payments from the local authority, they already have PAs in place, and you would want that to continue whilst you're setting up the PHB and the NHS is taking on the care package. So this is why you need good working relationships with your local authority for those cases where you have people transferring over from local authority direct payments into the NHS. But I would have thought 2 to 3 weeks if you've got good, robust processes in place and running well.
Be interesting to see how that compares to the length of time that an integrated funded package of care would be in place, or indeed NHS continuing healthcare. Because one of the things that people talk about when they talk about personal health budgets is it takes too long to do, and that's certainly not the experience if the processes are in place.
Alice and Stephen, I wonder if I can abuse chair's privileges and ask a question. I mean, well, one thing I would say is, having a lot of experience putting packages in place, that doesn't sound any slower than the more traditional methods of doing it. But I wondered whether you ever come across arguments from commissioners that what is being spent, that money is essentially being spent on social care, and why should it be us in the NHS? I mean, I know we hope that we've moved on from the is it a health bath or is it a social care bath days. But I mean, I was just struck with the Luton example that people were using this to buy extra home care. And do you get any pushback from people saying, hang on, well, why is the NHS paying for that? Why not the local authority?
Yeah, and I think it comes down to a focus on what the outcomes are that you're trying to achieve. And it has to be a health outcome, even if it's met in something that's a more traditional social care funded activity. And indeed, that's some of the aim of obviously of the Better Care Fund and things like that. Another question, do individuals have to have a separate bank account to receive a PHB for auditing? Yes, yes and no. Yes, they do. So similar to social care, there needs to be a separate bank account. The regulations say that for an ongoing budget. And that bank account, there's several reasons for that. Some of it's for auditing, but the other thing is so that the bank doesn't think it's their money, and if they've got an overdraft in their own account that they do some of that. So it's about that clarity of what the money's for. But if you have a social care personal budget and you're having a personal health budget for some aspect of care, it would be silly to make them have another bank account. So where you've got other benefit direct payment money coming in, you can have a single bank account. If it's a one-off payment, so if, for example, in mental health, some of the smaller budgets of a couple of £100 to do something innovative with, we wouldn't expect it to have a separate bank account for that one-off payment for auditing purposes.
Can I ask another one, which is whether this process can feed into EHCPs, Education, Health and Care Plans for 0 to 25-year-olds?
Oh yes, and we think it can help with transition from children's to adult services. And indeed, some of our IPC sites are focusing on children and young people. And I think it's really, really important. And within the Families Act, there are options for personal health budgets for some aspects of health. But in that group, it's when you think about some people having kids having 3 different wheelchairs and one's not allowed to leave the hospital, it just doesn't make sense to normal, to me anyway. How a PHB would differ between mental health and mental health support and Section 117. I think that comes down to the level of need. So we know that Section 117 is for aftercare after somebody's been sectioned under the Mental Health Act, and we know that people can be discharged with Section 117, have somebody who's got exactly the same levels of need but weren't sectioned, and they may access their mental health needs differently. So Section 117 is one area where we think a legal right might be beneficial, or for that level of need. But you could have mental health support, personal health budgets at a lot lower when your needs are lower. So as a preventative personal health budget, we've had some examples where people have been bouncing about the system, coming into accident and emergency because they've got nowhere else to go, and through care and support planning and sometimes small budgets, you can help them meet those needs and stop them being admitted or sectioned. Hopefully, does that answer your question?
And if I could just, Alison, add a little bit to that, just to remind people that Section 117 of the Mental Health Act is essentially to ensure that the individual is not means tested for their care. So is there a difference then, going back to the question, between a PHB for someone with Section 117 aftercare rights, the right not to be means tested, and support for anyone who doesn't have Section 117 care after rights? And it should be the same. The PHB process should be the same, and the care and support they should get should be the same, should they have the same care needs And should they wish to exercise or have their care needs met in the same way, they should be the same. There shouldn't be any difference. I mean, there may be a difference because one person may decide to have care and support in a particular way that meets their needs, and someone else may want their needs met in a different way. But in terms of PHBs, the process is the same, and even perhaps the level of funding. So if the person with Section 117 care after rights, who is not going to be means tested, they may wish to have counselling once a week for 1 hour. That might cost £80. £80 might be in the budget for that. Someone who doesn't have Section 1 care after rights may also have health needs around counselling and wishes to have counselling 1 hour a week. And guess what? That costs £80 because they live in the same area. And in the area where I live, it might be £80 an hour for counselling. Then that person, without the Section 117, should get £80 in their budget in order to access that 1 hour of counselling a week. So it should be the same. Remember, PHBs have to be equitable. They have to be fair. We have to treat people, I wouldn't say treat people the same, but it has to be equitable in terms of access to care and support services. So there has to be equity across the system. So just because someone is Section 117 doesn't mean necessarily that they get less or more than someone who's not Section 117, because it really is about assessed care needs and how those assessed care needs will be met.
Great, thank you. That's another question. Under the Care Act, there is clear eligibility criteria. Is there something similar available for PHB arrangements, given the themes around outcome-based support? That is a very good question. There's clear eligibility around NHS continuing healthcare because of the framework. In other areas, it's slightly different. And I suppose it's the difference between the way that social care, there's certain people who are eligible for social care, but if you think about it in its broadest, everybody is eligible for NHS services. It's just about what their level of need are, how their services can be tailored, and indeed what services they get. At the moment, there is a lot of variation across the country. We're aware of that, and that's because we're in the development phase for personal health and the expansion phase of personal health budgets. But if we go for increasing rights, well, then we will develop more clarity about when, say, for example, in integrated or joint budgets, somebody would be eligible.
Okay, our sight of the technology from this end doesn't indicate that anyone else is in the process of typing. Oh, Peter, you are typing a question. We will answer that if we have time, but otherwise we're going to draw this to a close. I would really like to thank Alison, Stephen and Rob for a fantastic webinar. It's been a really helpful sort of combination of the policy situation and the policy perspective, really practical advice on how you introduce PHBs at each stage of the process, and really helpful insights from Rob about the transformative difference these can make to someone's life. That reduction from 185 to 6 district nursing visits a year is quite telling, isn't it? So thank you very much. You should now see on your screen an opportunity to have your say on how useful this has been. From early next week, let's say Tuesday, this will appear on our website, a recording of this with the slides and a transcript of the chat box. So if there's sort of anything else, if you wanted to go back and check anything, it'll be available. Or you can get in touch, and there'll be contact details on there to get in touch and ask any further questions. So thank you very much for your time. I hope it was useful. I'm sure it was. And yes, again, thank you to Rob, Alison and to Stephen. Cheers.